I will also need to look over my shoulder because I did not bring a laptop. I'm sorry today. So as mentioned, I'm a genetic counselor. I work in a group of about 20 genetic counselors at the Provincial Medical Genetics Program, and our clinic is located at BC Women's Hospital on Oak Street in Vancouver. So we service the whole province of BC to provide genetic counseling as well as the Yukon. Most of our patients we see in person in our department, but we also do offer video conference appointments to people that are located further distances away from our clinic, and occasionally telephone consultations as well. So this presentation was previously done last year by a genetic counselor in Ontario, and she graciously provided it to me and allowed me to modify it somewhat for my presentation today, so I'd like to thank her. So I'm by no means an expert specifically in alpha-1 antitrypsin deficiency. I have met patients and done genetic counseling for that condition before, but as mentioned in my introduction, genetic counselors are here to basically educate people on the genetic basis of inherited disease, and to discuss with families and patients what the implications of their diagnosis is, not only for themselves but for their family members, as well as to help them decide who to tell, how to tell, and then if you're a patient yourself who doesn't actually have the diagnosis, do you want genetic testing to tell you whether or not you might develop clinical signs of the condition? So we help people facilitate that decision making. So basic genetics 101, in every cell of our body we have our genetic code, very tiny, tightly packaged in our chromosomes. This is a picture of a human karyotype showing our chromosomes all coming in pairs. So we typically get one copy of each chromosome from our mother and one copy of each chromosome from our father. If you were to unwind the genetic information that's in a chromosome, it would form into this DNA helix that you see here. Our DNA is then transcribed into RNA, and our RNA is then translated into our amino acids. And these amino acids are the building blocks for the proteins, and the proteins are what mainly have the function or the job in our cells. This is a picture showing some different types of genetic variants. So in the past, we tend to talk about genetic variants, and we used to call them mutations. And that has a bit of a negative connotation. It's also not very accurate. So there's been a shift in the last few years to talk about variants in our genes. And so what we have learned is that there is usually a typical code, a most common code for any sequence of a gene, but there is a lot of variation from one person to the next in the human population. And one of the trickiest parts of medical genetics is when you find a variant in a gene, determining whether or not it actually causes a problem. So determining whether it actually is pathogenic and affects the ability to make that protein or the ability of that protein to do its job. So we've now classified variants differently, and we base them on evidence to support whether or not we can be confident that it is either a benign variant and has no effect on the gene, or whether it's pathogenic and does have an effect and cause human disease. So we rate variants, and we can call them either pathogenic or likely pathogenic, or likely benign or benign, and then there's even a category in the middle where we just say they're a variant of unknown significance, and we're not sure whether or not it truly causes an impact or not, and we need to do further research to learn about that. So different types of variants would be where we have a typical code of a G, T, A, and C. There may be a letter that is changed, so a T to an A, or you may just delete one of the letters entirely or insert a new letter entirely, and there's a few other different types of variants. And how our genetic code is read is in groups of 3 letters. So a group of 3 letters encodes for an amino acid. So you can imagine if you were to delete out one letter in that string of code, you're going to shift the reading frame of those 3 letters all the way down from then on more. And that can seriously affect how that gene is read, or maybe it will not even be read at all. So the gene for alpha-1 antitrypsin deficiency happens to be on chromosome 14. And so like many genes, we have 2 copies of this gene. So all of us in this room have 2 copies of the gene, one that we get from our mother and one that we get from our father. So as some of the speakers before me have mentioned, this gene works, so it's made in the liver. If you have an alteration in this gene, then it can get gummed up in the liver instead of being released smoothly into the blood to go to the lung where it's to do its job. And so when you have alterations of the gene, you get these polymers that collect in your liver, and you get less enzyme getting to your lungs to do its job protecting from the protease. So in BC, our approach to diagnosing somebody with alpha-1 antitrypsin deficiency, so if this is someone who has clinical signs or symptoms of disease and presents to a doctor, and the doctor wants to test for alpha-1 antitrypsin deficiency, they would first order the serum level for alpha-1 antitrypsin, the enzyme level in their blood. And if that comes back below a certain threshold, that will lead to the next step, which in BC is actually the PCR-based genotyping. So this is a very quick, specific genetic test that will test for the presence of the Z allele or the S allele. So only those particular 2 variants will be tested for immediately. And the reason for that is because they are the most common pathogenic variants for alpha-1 antitrypsin deficiency. So if someone has alpha-1 antitrypsin deficiency, 95% of the time they are either ZZ or SZ. So they'll quickly test for that. They will also sometimes use the PI phenotyping, or that was the image I'll show you coming up as well, this one, where actually before they even identified the gene, this was the way of telling which copies of the gene someone had. So someone who has 2 normal copies of the gene had MM, someone who had 2 abnormal copies was ZZ, and someone else was MZ, they were a carrier. So before the gene was identified, it was recognized that the proteins were altered and therefore they ran differently in these gels. So still today we use this in labs because it is quite cheap and it's a good tool. It also can pick up different variants in addition to the Z and the S. So in the lab, they will do the enzyme level as well as then going to the PCR genotyping plus or minus the isoelectric focusing, and then they will issue a report. If that's non-informative, so if it looks like someone has low levels of the enzyme, but they don't appear to have the ZZ or SZ combination that you would expect, they can go on to full gene sequencing, so reading the entire code of the gene and looking for other rare variants that aren't picked up by those previous methods. So it's more expensive, a bit more labor intensive, and not often needed, so they start with the cheaper, quicker test first. The variants that they pick up with the sequencing are individually quite rare and a bit more common in ethnic backgrounds that aren't Northern European. So there are a lot of different variants that have been identified in the alpha-1 antitrypsin gene. It's actually quite a common condition, and many people know that it's undiagnosed in a lot of people. The carrier frequency of the Z allele in the Northern European population is about 1 in 25, depending on the study and depending on exactly the population that they're testing. And then the carrier frequency of the S allele is even a little bit higher, about 1 in 12 people are carriers of that if they're of Northern European background. I was curious a little bit about the genetics of that and how long ago this variant was introduced into the population. And it appears to have been dated back to about 2,000 years ago to the Scandinavian population and perhaps spread by Vikings as they spread through Europe. I also, as a genetic counselor, believe in natural selection, and I always wonder what might have been the selective advantage to being a carrier or being affected. You have to wonder that when something has such a high carrier frequency in the general population. So I did a little bit of research to see what the hypotheses about that might be. And some of the ideas are that having a bit of inflammation in your lungs, so being a carrier or even being affected, back 2,000 years ago or even 1,000 years ago may have been beneficial in actually preventing bacterial infections or making you less susceptible to bacterial infections. So this is in a time where antibiotics did not exist. And then over the years, as we discovered antibiotics and had that treatment, as people started smoking, that became a lot more detrimental to be a carrier or be affected with alpha-1 antitrypsin deficiency. And then also just in general, our longevity has increased dramatically in the last while. So people are living longer because they're not dying of other things. And so we're seeing the detrimental effects of being a carrier or being fully affected with the ZZ allele as you get older. So both copies of the gene are doing a job. So both copies of the gene are making a protein. So if you have 2 copies of the M, or the normal, you're making sort of 100% of the potential for the enzyme. If you're a carrier and you have 1 normal copy and let's say 1 Z copy, you're making a reduced amount of the enzyme. However, the decrease in the amount of enzyme is not usually enough to make you at quite significant risk for emphysema or liver disease. If you have ZZ, you're making a significantly less amount of the enzyme, so you're at much higher risk for emphysema and liver disease. This is just a schematic of what the gene looks like, and the 2 circled areas are where the variants for the Z allele and the S allele are. They're just simple point mutations, so the first one, just 1 letter switched in each of the spots. So which patients are referred to medical genetics? So basically, any patient with a personal or family history of alpha-1 antitrypsin deficiency is eligible for genetic counseling. All our patients have to be referred by a healthcare provider, so we don't accept self-referrals, but it can be any healthcare provider. It can be your family doctor, it can be a specialist, it can be a nurse practitioner that can refer. I did a quick search of our database. It's a very simple, very outdated database, so it's not comprehensive by any means, but I had a little look to see the numbers of patients that we might see in a year. So this year we saw 5, last year we saw 8. So it's not a huge proportion of the patients that we see. It may be a reflection of quite a few things. One may be under recognition of the condition itself or under diagnosis, but also just maybe not recognition of the option to refer for genetic counseling by other healthcare providers. But we're very willing to see people. So a common referral might come in from someone who is a ZZ person. So they might come in having been newly diagnosed and want to better understand what that diagnosis means for themselves and for their family members. So the genetics of this condition, some might describe it as autosomal recessive, other people describe it as codominant, which basically means that usually if you are ZZ, most likely each of your parents is a carrier of 1 copy of the Z allele and 1 copy of the normal allele. And usually carriers are unaffected and healthy. So that's recessive inheritance. Codominant inheritance just tries to highlight the fact that both copies of the gene are functional and that there is a measurable effect of having 1 copy of the gene not working. So your enzyme level is a bit lower if you are a carrier, but just not usually into the clinically significant range. So when we were seeing a patient such as this, we'd want to highlight to them that the people at highest risk in their family are their brothers and their sisters. And so we would like to find out how many brothers and sisters do you have? So we do a family tree. So it's great when people come to their genetic counseling appointment with some family history information already there. So we'll draw out their family tree, how many brothers and sisters they have, their parents, their children, and we'll start talking about who has the option for testing. So essentially, any first-degree relative of someone who's been diagnosed with alpha-1 antitrypsin deficiency is eligible for genetic counseling and genetic testing should they desire the information. Certainly, the siblings would be the people that would be most important for them to be informed of the patient's diagnosis and the option for testing. But when it comes down to it, the patient that I have in front of me, their information is confidential. And so there are family dynamics that come into play. People are estranged from their siblings or their parents, and some people that just would rather keep the information private. So my obligation is to my patient, so I can't find out who their brother or sister is and call them up and secretly tell them. It's really up to the patient themselves to inform their brothers and sisters. So we would strongly encourage people to do that. We also can't control then, though, what people do once they are informed of that. So some patients get quite distressed because they'll say, I've told my brother or I told my sister that they could have this, and they just aren't doing anything about it. They don't believe me, or they're just not interested in doing it. So I try to make people understand that really ethically and morally, the best we can do is what we call the duty to warn. So you do your job by sharing your personal information and how it might impact them. And it's really their option and their choice whether or not they pursue genetic counseling or genetic testing for the condition, and it's not for everybody. So that's all you can really do. Now, one thing to always keep in mind is that if you have someone who is ZZ themselves, most likely their parents are each a carrier of one normal copy and one Z copy. But I did highlight the fact that the carrier frequency of this condition is quite high. So anytime you approach genetic testing for an individual and you expect that they are going to be at least a carrier, we also have to counsel about the possibility that they also could be affected, because perhaps each of their parents, so the grandparents, were also carriers. So you have to really be open to that possibility that when you're doing genetic testing, even if you don't have any symptoms of the disease, you might presume, if anything, I'll be a carrier. Well, you actually may end up discovering that you have two deficiency alleles and may be at risk for the health complications from that. So it really depends on what each parent carries in terms of what the risks are for their children. When someone themselves is affected with the condition, if they're thinking specifically of their children, all of their children will be what we call obligate carriers. So someone who has two copies of a deficiency allele only has that to pass on to their children. So all of their children will get at least one copy of the Z allele if they're affected. So then it really depends on what their partner has in terms of what is the risk for their child to have alpha-1 antitrypsin deficiency, the disease. So we do offer carrier testing to partners, so people who have married into the family where there is alpha-1 antitrypsin deficiency, in order to educate what are the risks for their children. So we can do it either way. We can test the children themselves, we can test partners to learn what the risk is for the children. Some people ask about prenatal or pre-implantation genetic diagnosis for alpha-1 antitrypsin deficiency. So if we know the specific variants that are causing someone's disease, it's technically possible to do prenatal diagnosis. So take a sample during a pregnancy and tell you whether the fetus has the ZZ or MM or MZ. It's also technically possible nowadays to do PGD, which is where we take eggs outside the body and sperm and make embryos, and we can test embryos and select and only transfer unaffected or carrier embryos back into the womb. It's a pretty uncommon request for typically adult onset conditions. The other complicating factor is that I often say to my patients, you're never the product of just one gene. And so we can test for that one gene, but we don't have the ability to predict exactly when someone might develop signs or symptoms, or if they ever will develop signs or symptoms. They could get another health condition and pass away from that before they ever present with symptoms related to alpha-1 antitrypsin deficiency. So we can detect the presence of the alleles, but we don't have a crystal ball to know exactly how their health will play out in their lives. The exception where someone, in some cases, may consider prenatal diagnosis or PGD would be the more rare case where some infants have quite severe liver disease. And there are, sadly, some cases where infants have died or young children have died related to their ZZ combination and their liver disease. And in those families, we know that although that liver complication is rare, if it's happened in your family, there may be specific other genetic modifiers that are in your family, or just the environmental factors that are around us that we don't exactly fully understand. We know that the risk for recurrence in a sibling to have liver disease and serious complication is significantly increased, measurably increased, compared to the background risk for other people with ZZ. So there may be a case where a family is really grieving over the loss of their child and can't imagine potentially having that happen again, where they might consider something like PGD moving forward for their next pregnancy. So to finish, I wanted to talk a little bit about genetics and insurance. So as a genetic counselor, I do bring this topic up with my patients. I'm definitely not an expert in insurance or in the law around insurance. And if patients have a lot of specific questions or concerns, I certainly would recommend that they speak directly to an insurance broker or a lawyer. But there's some basic discussion topics that we talk about. So essentially, we talk about genetic discrimination, or the potential for genetic discrimination, and that can come in many different forms. Probably the most commonly raised question or concern is, how will this affect my application for life insurance? So this is usually coming from patients not who specifically have already been diagnosed with alpha-1 antitrypsin deficiency, because those individuals have the diagnosis. If they're going to apply for life insurance, they're going to have to disclose that. But it's more for the individuals that are looking to do the genetic testing at more of a predictive thing. So they're currently healthy, and they have no signs or symptoms of the complications related to the condition, but they potentially, if they give blood, could find out that they have ZZ. And so now we know that they are predisposed to having an increased risk for lung disease or liver disease. And how will that impact my application for life insurance or mortgage insurance? There's also the potential for genetic discrimination in the workplace. So there have been some companies in the US, I'm not so sure about Canada, who have actually given genetic tests to their employees to decide whether or not to hire them, or whether or not to give them benefits and things like that. So there was needs for laws to protect individuals from having to do that. So excitingly, last year in May of 2017, the Genetic Non-Discrimination Act was passed in Canada. It is a federal law, and it basically aims to keep your genetic test results private. So an insurance company is not supposed to be allowed to ask you for copies of your genetic test results or look at them in determining what rates they're going to issue you or charge you for your insurance. It also applies to, there are some clauses in there about genetic discrimination in the workplace as well. The main hope of it was to reduce barriers for people for accessing the genetic testing and the genetic counseling. So some patients were declining genetic testing because of the fear of discrimination. But when we know that there are clear potential benefits to know your status, maybe you'll make significant lifestyle modifications if you knew you were predisposed to emphysema, or you change careers where you're not exposed to the same toxic things in the environment. So under this act, it protects us from having to be required to do a genetic test. So for example, before this act existed, if you told your insurance provider that you had a brother or sister with alpha-1 antitrypsin deficiency, if they did a quick search and they realized that you could do a genetic test to find out if you could have it or not, they might actually have required you or asked that you do the genetic test so that they could make a call in whether or not to insure you. So they cannot require you to do a genetic test, and you do not have to disclose the results of a genetic test. You just have to answer questions about your personal medical symptoms and your family history. In some instances, it might actually benefit you to disclose your genetic test results. So for example, if you have a family history of alpha-1 antitrypsin deficiency, for example, your brother is affected, and you've done a genetic test that says you got 2 normal copies of the gene, then really they shouldn't factor in your family history of that disease into your insurance and your rating. I'm not exactly sure how that will play out. I hope that it could be that you could just sign a form and say, I consent to sharing this genetic test result as part of my assessment for insurance. So the things that they qualify as genetic tests would anything that analyzes your DNA, your RNA, or your chromosomes. And it applies to both tests done in a clinical or a research setting. One example that would mean that is not covered is something like an alpha-1 antitrypsin enzyme level. That's not technically a genetic test. So that's something that they could have access to. The caveat to this law that we're all really hesitantly watching is that this is a federal law, so across all of Canada, whereas the insurance industry actually is provincially governed. And so immediately after this law was put into place, Quebec has challenged the law as a province, and they're going to court in Quebec to challenge it as unconstitutional because it infringes on their provincial legislation. So if they were to win that court case, then my understanding is that it would go to the Supreme Court, and then there's a chance that this could be overturned. We don't know exactly what that will do to people in that in-between time. So if you've had a genetic test in that time and then ultimately this gets overturned, hopefully it won't apply to people that were tested during that time, but it could. So in general, what I would recommend to patients when I see them is I first ask them, do you currently have insurance? Are you happy with your level of insurance that you have? Or as many of you have, and many people do that I meet, is like, I haven't even looked at it, I haven't thought about it. It's one of those things that people put off. Truly, you should always be applying for insurance when you're young and healthy, and that's the time that most people are not thinking about it. And so often people are thinking about it more when they start to have children. And so it's very reasonable if you're doing predictive genetic testing, so you're currently healthy and it's not going to alter your medical management in the immediate time, is to put it on hold, get your life insurance in place while you're young and healthy and make it a long-term plan, and then come back and do your investigations. So if someone already has their life insurance and mortgage insurance and it's in place, then there's really not a concern at that point. So thank you, and I'm open to questions.
I'm not an expert, but I am a licensed insurance broker,
Okay.
and in a couple of provinces, and have been in the field for over 10 years.
Uh-huh.
And I can provide a little bit of information on that. Is that it depends so much on the insurance company as to which questions they ask, and also many companies will let you have different levels of insurance depending on how far you can go with your questions. I think it's a little bit of a slippery slope to say that that act has anything to do with whether or not we provide our genetic information, because the majority of the companies that I deal with want to know information about your mother, your father, and your siblings as soon as you get up over sort of a minimum amount of insurance. So whether or not, and I'm going to definitely ask this question of some of our companies, whether or not you could actually provide the genetic test for yourself and say that, well, I'm exempt from all this. That would be an interesting question. I'm not so sure about that. But the way you're sort of portraying it is that we wouldn't have to give that result. No, we wouldn't have to for ourselves in many companies, but in many instances, you're not exempt from saying any information that you have about other family members.
Yes, so sorry if that was misleading. Certainly, you have to disclose your family history, on my understanding, on many basic insurance applications. So you do have to say if you have a brother or a sister or a parent who has heart disease or alpha-1 antitrypsin deficiency. What you don't have to disclose is if your brother has alpha-1 antitrypsin deficiency, he told you, and so you went and did a genetic test even though you have no symptoms, and you found out that you have ZZ. But you're currently healthy. You haven't had an enzyme level showing your low level. You did it for preparation, modification, or reproduction information. So definitely you have to disclose your family history. I do know from other genetic diseases, even before this act came into place, so a common one is Huntington's disease really affects insurance. So if you have a family history of Huntington disease and you did a genetic test that said, my parent has it, but I didn't get the gene because it's a dominant condition, that you have been exempt from that. Part of it has been removed from your calculation, but sometimes it takes 2 or 3 letters from different specialists. So a neurologist saying they have no signs or symptoms and they've done the genetic test, and a genetic counselor writes a letter, and a geneticist writes a letter. So sometimes you have to be really relentless in getting them to acknowledge that you've removed that risk from your family history. And I also understand or empathize with the side of the insurance company. They're trying to do risk benefit. They're trying not to pay people out, and they're trying to base that on a risk assessment of an individual. And if they knew that someone had a predisposition to emphysema at a young age, then they might want to be more likely to give them a higher rate because they're more likely to request the money. So I think it's something that we'll just have to keep an eye on. Any other questions? Thank you.